that I've chosen is the 4 years early rises, early age targeted prevention intervention effect on the aggressive children's peer relation that have been conducted by August, Egan, Remuta and Haslin in 2003. This study has been taken for 4 years to complete all the intervention, and the early rises program itself is the preventive intervention that has been targeted aggressive elementary school children that is highly risk in the developmental and the serious antisocial behavior. 1,489 students have been participating in the intervention, including 125 samples from early rises program. And the students that we recruit is via multi-dimension identification and recruitment procedure, which is the student that have been through this recruitment have been identified to be moderate and high in level of aggression. And to do this intervention, 75 of children in the program have been done the intervention, and the rest 50 children are not joined the intervention. So the rest 1,364 is the classmate that has been recruited in order to provide the peer assessment to the intervention. The intervention, the first thing is the annual week, the annual 6-week the summer school program that is being held by using intensive academic skills instruction, social skill acquisition in the natural setting. Plus, it is to involve with non-aggressive peers and integrated with program aggressive peers, which is called the buddy system. And this kind of program is to offer specialized training and to experience in creative sports, creative arts, and it is to provide opportunities to recreation and field trip. And secondly, there is the family program. This is the bi-weekly session that has been held between October to May each year, which is this program is targeted the parents of the children to gain knowledge and to do the skills training around affecting parenting practices, which is how to support the kids, how to give support on their school engagement, such as they have been in the competition of something, and on top of that they could learn on how to do parent stress management. And intervention also, besides the school-based monitoring and mentoring, school consultant program is also being held. This is the systematic assessment of the children's academic functioning, school comportment and peer relation. It is also followed by mentoring option, including the relationship building, classroom recommendation, behavior program, and the academic tutoring. In intervention also, there is the flex family support component, which is including the family education support and empowerment of the program. And this is the process where the parent, the child, and the family in the need of assessment through strategic goal setting in the offer brief intervention to resolve crises and specialized services through negotiation contract with the participant. How this intervention is being measured and the assessment procedure is being held is the severity child aggression, and how this severity that being measured is the parents and the teachers are playing an important role. So the teachers and the parents have been given the inventory, which is for the teachers is given the teacher's observation in classroom adaptation revised, and the parents have been given parent observation of classroom adaptation. And both of them include 14 items, and the parents and teachers have been given this inventory to evaluate the students or the children in terms of their behavior in the previous 4 weeks. And the second one is the how to measure the peer reputation nomination is firstly is to a different role. And then the number of nomination on the age roles is entirely standardized by the gender, and then it is being compared and combine the nomination standing across the classroom. For measure the likability, there is the students have been participate there, being give introduction, which is they have to nominate 3 of their friends they like to play with, and the other 3 friends they don't like to play with, and they compute the data, and then they subtract the likely score with a like score. The friendship selections, there is an instruction where they have to select their very best friend and the other 2 that they consider as their friends, and the peer repetition score or RCP that's tabulated for each child that has been chosen as a friend. So how to measure their friendship qualities based on the intervention, they are being instructed to rate one of their best friends in the class in the 5 scales. But firstly, if the validation and carry, secondly, companionship and recreation, and the third one is the help and guidance, and the fourth is the aggression to within the friendship, and the lastly is the aggression to the others. Based on the overall intervention, the third year assessment or intervention, there is finding that teachers and parents rating on the problem child is having more positive social skill rather than the control group. And then in the 4th years of intervention, the social skills for the problem children also has improved to favorable peer repetition and the friendship selection. Other than that, children also choose less aggressive peers with more positive qualities rather than the control group. So in the overall, that I can be conclude that this intervention had been helped the aggressive children to improve themselves in the social skill and the overall the peer relation. So because the data itself shows that there is a difference between the children that do the intervention with the children that didn't do the intervention.
For aggressive disorder, I chose behavioral approaches to the treatment of aggressive disorder by Peter A. Fehrenbach, University of Washington. So mental health professionals are often called upon to work with individuals whose behavior is characterized by excessive or inappropriate aggression. Aggressive behaviors are among the most frequently reported behavior problems for which children are referred to outpatient clinics. Effective treatment of aggression in children and adolescents is especially important since aggressive patterns of behavior tend to either persist or become even more problematic over time. Aggression in childhood has been associated with development of psychotic and antisocial behaviors in later years. But for adults, aggressive behavior can lead to the failure of intimate relationship, loss of employment, and high chances of going to prison. Aggression is a wide variety of verbal and motor behaviors such as striking, scratching, choking, biting others, to relatively mild verbal disqualification of a spouse statement. So there are few behavior modification technique. Number 1 is extinction. So tantrum behavior, there is a case of a tantrum behavior of a 21-month-old boy was eliminated by an extinction procedure in which the parents ignore the rages of the child at the bedtime. In other reported cases, parents are trained successfully to eliminate aggression by not giving attention to aggressive behavior while also reinforcing prosocial responses. And number 2 is time out. Extinction does work to reduce aggressive behavior, but it requires a long period of time to be effective. So time out involve less chances of injury or destruction during the initial stages of intervention and can produce more immediate effects than extinction. In uncontrolled cases, TO or time out alone was effective in reducing intimidation and aggression in an institutionalized delinquent male. In other case, reported a mother was trained to use a combination of timeout for aggressive behavior and reinforcement of appropriate behavior for their 8 years old son. So number 3 is contingency contracting. So behavioral contract specify beforehand the problem behavior, the responsibilities of parties involved, and the consequences that aggressive and pro-social behaviors will be produced. Such contracts may be more effective to control aggressive behavior because they reduce the amount of trial and error behavior. Kersey on 1969, Blackham and Silberman reported success using behavioral contracts with chronicle aggressive children. And number 4, the last method is comprehensive retraining programs. This program rely primarily on training the parents and other significant individual with whom the child interact in use of learning principles as a means of controlling aggressive behavior. The parents are introduced to the principles of learning and child management through program text. Then, the parents are taught how to select target behaviors and how to collect data based on the observation of their children. Finally, specific child management techniques are taught by means of instruction, discussion, rehearsal, and social reinforcement. All techniques are acceptable because they are scientifically proven to reduce and eliminate aggressive behavior. The only difference is duration for those techniques to be effective.
Assalamualaikum, I'm Amirah Binti Amizan, matrix number A167481. Article that I choose is Aggression by Behavioral Therapy Techniques. This research is to investigate the effects of behavioral therapy techniques through operant conditioning and observant learning on children's aggression aged 4 to 6 years old. Aggression is defined as a deliberate behavior to harm others. In particular, aggressors believe that their action hurt others. Aggression among children appears in various forms, like verbal calls, disobedience, destruction, opposition, and obstinacy. Aggression seems affected by time and have high intensity and very specific mental developments. Aggressive behavior as a stable personality trait, however, can affect others' behaviors throughout childhood and on into adulthood. Moreover, they expect more negative social outcomes and may behave less competently in new situations. In adults, the consequences include physical injury, psychological trauma, and financial costs. A pre-test, post-test, quasi-experimental study with 2 experimental groups and a control group was designed by researchers. They used non-probability purposive sampling method to select photograph mothers out of all mothers of aggressive children.
Apparently, tests were used. The mean score of the aggression and its components for the operant conditioning therapy group are lower in post-test compared to pre-test. The mean scores of the aggression and its components for the observational learning group are lower on post-test compared to pre-test, and the mean scores of the aggression and its components for the control group are higher in post-test compared to pre-test, except for the relational aggression score, which is the same in pre-test and post-test. The result of multivariate analysis of covariance on the aggression scores of the operant conditioning group indicate a significant difference between experimental group and control group in terms of aggression and its components. The result indicate that teaching operant conditioning and observational learning techniques to the mothers reduce their children's overall aggression along with its components, including verbal offensive, relation of aggression, and impulsive anger. Ozabaku concluded that cognitive and behavioral therapy methods can reduce anger in children, while Kawabata and others examined parenting methods and its relationship with aggression and indicate positive parenting methods can reduce the aggression level among children. These techniques are recommended to be used in clinical intervention to teach the families how to control the children's aggression. I'm Amirah Binti Amizan, matrix number A16741. I had choose article of Dove Press in Clinical Cosmetic and Investigational Dentistry, which is strategies to manage patients with dental anxiety and dental phobia. Dental anxiety and phobia result in avoidance of dental care. It is frequently encountered problem in dental offices. Formulating acceptable evidence-based therapies for such patients is essential, or else they can be a source of stress for the dentist. The initial interaction between the dentist and the patient can reveal the presence of anxiety, fear, and phobia. Overwhelming and irrational fear of dentistry associate with devastating feelings of hypertension, terror, trepidation, and unease, which termed as odontophobia, has been diagnosed under specific phobias according to Diagnostic and Statistical Manual of Mental Disorders, DSM-5. In such situations, subjective evaluations by interviews, self-reporting on fear, anxiety skills, and objective assessment of blood pressure, pulse rate, pulse oximetry, finger temperature, and galvanic skin response can greatly enhance the diagnosis and enable categorization of these individuals as mildly, moderately, highly anxious, or dental phobics. Dental anxiety can be managed by psychotherapeutic interventions, pharmacological interventions, or a combination of both, depending on the level of dental anxiety, patient characteristics, and clinical situations. Psychotherapeutic interventions are either behaviorally or cognitive oriented. Pharmacologically, these patients can be managed using either sedation or general anesthesia. Behavior therapies is to change unacceptable behaviors through learnings and involve muscle and breathing relaxations. Cognitive strategies is to alter and restructure the content of negative cognitions and enhance control over negative thoughts. Dental anxiety can arise due to multiple factors. For example, previous negative or traumatic experience, conditioning experience, and vicarious learning. Psychological and pharmacological interventions are both equally effective in reducing dental anxiety and phobia. Response to behavioral and cognitive therapy is not immediate, and multiple sessions are usually needed to maintain initial treatment response. In conclusion, dental anxiety and phobia can have adverse impact on a person's quality of life. Hence, imperative way to identify and alleviate significant obstacles to pave the way for better oral health and overall well-being.
And that the other article that I have been choosing for intervention for the dental phobia is the dental phobia treatment within the Swedish National Health Insurance, which is this is the Dental Fear Research and Treatment Clinic, or DFRTC. This is the model for the National Health Insurance System, which is specified in the dental phobia treatment. The Gothenburg model has been conducted since 1975, and then there is a phobia treatment that DFRTC that have been followed, which is the first one is the examination, the second one is the treatment, and the third one is the follow-up. So during the examination, they have to be examined by a maximum of 10 times, 10 treatment, which is the first one. They have been examined by the dentist. It is including interview and the psychometric questionnaire, and then the second one they have to be examined by the psychologists, psychiatrists, and psychotherapists, and then the rest of the examination has been conducted by consequences board. The participants that have been participating in the study are verified to be someone or a patient that having a dental phobia, and there are criteria to verify that. So the first one is they are not having or going any dental appointment or treatment for several years, and the second one is they are verified to be someone that really having dental phobia, and they are being approved by psychologists, by psychiatrists and psychotherapists. In the study, they are divided into two groups, which is the first one that have been given general anesthesia, and the second one that have been given a behavior treatment or therapy. So the first group that they have been given anesthesia or sedation wherever they are having the phobia. So this medication helps them to not feeling sick and able to overcome their phobia. So the second one is the behavior treatment. This is consists cognitive behavior treatment, and there are some intervention onto that. The first intervention is the during the psychological term, there are interventions that are adapted to the individual patient's needs, as identified at the initial assessment and functional behavior analysis. And the second intervention, there is a very common use, which is the psychoeducation, which is in this intervention, patient learns how to learn that the fear is really adaptive. It is normal to feel fear whenever they feel scared or when they feel threatened, and they learn that feeling is normal. And other than that, the psychoeducation also adds an exposure to the patient that they can approach the things they don't like or they are scared of, and this kind of experiment that have been feel bodily sensation or their thought and the feeling of fear, they are remembering that. So in order to overcome their phobia, there are certain techniques that are being taught by psychologists or psychiatrists in order to patients to overcome their phobia. So one of the technique is relaxation and calm breathing. so that they can control their psychological reactions, so it can build the facilitates exposure. Other than that, in order to increase the relaxation, there are another technique that I've been taught, which is the biofeedback technique, which is whenever they do this kind of technique, it is can facilitate exposure as well, and it is can do a systematic desensitization. In addition, patient also can do self-assertiveness training, which is the patients can communicate with others, communicate to show out their true feelings, their thought, and their feelings and their needs in a more constructive way. But this kind of training is really when it is needed and when appropriate time. After finish all the session with the psychologist, there are another session with the dentist, which is the clinical rehearsal, and this is one of the therapy plans so that the patients can practice and evaluate the new strategies in order to face their phobia. And then this kind of therapy also are for giving the preparation for the patients, and this also have been give an ongoing info so that the patients can increase in control their behavior, and this is a gradually exposure to them, and this is to increase the positive reinforcement to the patient. And the last part is during the behavior therapy, the patient or the participant are being referred to the general dental care, so they can do a follow-up to the new dentist, which is they've been give follow-up questionnaire to the dentist in order to examine the patient's cooperation in the treatment and patient rated in the dental fear. So the outcome from the Gutenberg model is there are both treatment are giving positive effect in the short term and a long term effect. And the behavior therapy group, they have been shown that 92% of them are being referred to the general dental care, and this shows that behavior therapy is being an effective way to decrease their patient dental phobia. In conclusion, it is undeniably both of the treatment have decreased the dental phobia, but it can be denied that the behavior therapy have been shown a more effective effect to the patient in order to reduce their dental.
Assalamualaikum. My name is Noramirah. My metric number is A168301, and today I'm going to talk about dental phobia. So the journal that I chose is long-term management of fearful adult patient using behavior modification and other modalities. There are a number of behavioral treatment methods that can be used by dentists for the reduce of fear and anxiety in the dental office. Considering the high number of fearful adult individuals visiting dentists regularly, a better knowledge about such methods will improve the dental care for the majority of the patients. It will also help prevent inference of fears among individuals at risk. Up to 40% of adult population admit to have been fearful of dental treatment, but only 3 to 5% can be said to be truly dentophobic. In this research, they use systematic desensitization or SD as behavioral approach. SD first come to widespread attention when Wolf presented his theory of reciprocal inhibition. SD uses relaxation to counteract and weaken the connection between the anxiety-provoking stimulus and the response during gradual exposure. These are the steps for SD. 1. Construct the individual anxiety scale for the patient to use to report anxiety at each stage of treatment, which encourages with better communication between the patient and the therapist. Second is to construct a hierarchy of situations progressively more threatening and anxiety-provoking. 3. Train the patient in a relaxation technique. And 4th, gradually expose the patient during realization to the hierarchy, starting with the least threatening situation. These studies has demonstrated a reduction in self-reported dental anxiety, and they also have indications of that treatment has a positive influence on general states of fear, anxiety, and mood. The successful rate for this treatment is 70 to 80%. Dental phobia and any other specific phobias involve intense fear of specific object or situation. In contrast to many other phobias, sufferers subject themselves to regular and repeated exposure to threatening stimuli or may be expected to do so. Just like any other specific phobias, sufferers will avoid the feared situation, in many cases lead to significant negative consequences. For the truly phobic individual, it is common for vicious cycle to develop in which fear leads to avoidance of dentists, resulting in neglected dental care and feeling shame of their appearance. These factors give negative social effects and hence increase anxiety.